Hello, how are you? I'm Dr. Usman. Today I will discuss about approach to hypokalemia with or without uh, hypertension. Actually, we will discuss by learning during scenarios. A 28 years old female comes to OPD with history of generalized muscle weakness for 5 months. On lab investigation, there is hypokalemia, that is serum potassium is 3.2 millimole per liter, and blood pressure was between 150 over 90. This is between 150 180. She was started on full sartan 40 milligram OD. She was certain is ARBs, and this causes hyperkalemia. She came back to OPD after 7 days for follow-up. Her repeat potassium was still 3.3, 1 millimole liter above the previous value. Her blood pressure was again measured and was 170 over 100 despite of taking valsartan. It means blood pressure have been switched from 150 over 90 to 170 over 100. Consultant started workup for secondary causes of hypokalemia as well as for the hypertension. Renin and aldosterone is ordered. Her renin is very high along with aldosterone levels. It means both are high. Ultrasound KUB, kidney, urinary and blood shows asymmetric kidneys. This means one kidney is almost 10 centimeter, other is 5 or 6 centimeter asymmetric kidneys. While you know that the normal kidneys we use the mnemonic 10, 5 or 2.5. Then what will be differential diagnosis and how to approach? Okay, same scenario but having low plasma renin activity with high plasma aldosterone levels or concentration. What is your differential diagnosis and what will be the further investigation? Okay, next third scenario with proximal muscle myopathy and strias. You know that is something about Cushing syndrome with plasma renin activity low and plasma aldosterone concentration low. Both are low. And what is your differential diagnosis? Okay, we will discuss it later. Okay, this is the basically algorithm you can discuss, or you can use this to monitor the hypertension with hypokalemia. Okay, we know that the serum potassium in our patient was 3.2 millimole per liter. Then what is your next plan of management? You should check for the urinary potassium level, and here we are not given the urinary potassium. So if the urinary potassium is less than 20 millimole per liter, that is something 10, 12, 15, and you will get about the history about diarrhea, vomiting, etc. It means that gastrointestinal losses are there. Okay, if the potassium level is greater than 20 millimole, then what will you do next? You will check the hypertension, you will check the blood pressure of this patient. Here we, in our scenario, these two points are skipped here. Check urinary potassium, it will be above 20 millimole per liter, then you will go towards the blood pressure. And here we are directed towards the blood pressure, and here our blood pressure was 150 over 90. Okay, if the patient has got hypertension positive, that the patient has hypertension, we have discussed it previous scenario number 1, which was the blood pressure which was about 180 or 170 around about blood pressure, systolic blood pressure. Okay, then what will be your next investigation of choice if the patient has got hypertension? If the patient has got hypertension, you will order renin concentration. Okay, in our scenarios, next 1, 2 or 3 scenarios, we are given 3 different kind of renin concentrations with aldosterone levels. And now we will check the renin concentration, and so this was quite high in our scenario number 1. So normally we will make 3 differential on the basis of renin concentration, high renin concentration, that is malignant or accelerated hypertension, renal artery stenosis, and the causes of renal artery stenosis, that is fibromuscular dysplasia, etc., and diuretic therapy if the patient is already taking. And we are told about the patient is not taking any kind of diuretic therapy. So here we will discuss about two things only. If the renin concentration is high, it would be malignant hypertension or renal artery stenosis. And we are told about that this patient has got first presentation. So on the basis of high renin concentration, we will make differential of these three most probably, and we will go towards the taking of renal artery stenosis. And renal artery stenosis, the most common cause in female is fibromuscular dysplasia. Okay, Achha. If the renin concentration are low, then you will make the diagnosis three differential most common. If the patient is not having congenital adrenal hyperplasia and age is somewhat not here between less than 20 or 10 or 20 or 5 or 6 years. So we will discuss about the adult causes. That is what we are here given: Conn syndrome, Cushing syndrome and Liddle syndrome. Okay, here the further differential will be upon the plasma aldosterone activity, that is plasma aldosterone concentration. So if the renal level are decreased, then you are checking the aldosterone level, and these are aldosterone level are high. Then what is the cause? If the aldosterone level are low, then what is the cause? If the renin concentration is low and aldosterone is also above the normal range, that is endocrinology says that if the plasma aldosterone level is more than 20 times of normal value, that is probably the Conn syndrome. Okay, Conn syndrome, there are more differential. Conn syndrome causes adrenal hyperplasia, any kind of adenoma, etc., etc. Okay, if we are making the diagnosis of Conn syndrome, then this will be aldosterone level more than 20 times. Okay, if we are making the diagnosis of Cushing syndrome, then what will be the effect on aldosterone concentration? Okay, what will be the effect? You know what will be the effect. If we are making the Liddle syndrome, this will present, the patient will present, age is not here, present with decreased renin, as we are told, and decreased aldosterone levels. You should know this, that this will be the low aldosterone levels. Okay, you got it? Okay, next, this is the basically we are talking regarding this, and you will find that the Cushing syndrome patient has decreased renin activity as well as decreased aldosterone level, and we will make differential between Cushing syndrome and Liddle syndrome by measuring HCO3 levels. Both of these causes the metabolic alkalosis, but the Cushing syndrome we should be given regarding history, that is proximal muscle myopathy, strias, etc., etc. And about the DOC producing tumor, deoxycorticosterone, that is just like corticosteroid, and you will read about in my next video. And this tumor can produce DHEAS level, which were probably high, and patient in these tumor patient as having excessive hair growth on body, and congenital adrenal hyperplasia, the age will be there. If the virilizing forms are non-virilizing forms, exogenous mineralocorticoid, that is patient was taking fludrocortisone for the Addison disease, DOC producing tumor, Cushing, L11 beta hydroxysteroid deficiency, that is somewhat liquorice or carbenoxolone therapy will inhibit it, Okay, that's why we got plasma renin activity low and plasma aldosterone concentration low. Altered aldosterone metabolism and liddle syndrome. Okay, if the renin activity is low and the plasma aldosterone concentration is high, here it is given that more than 20, then you should investigate primary hyper aldosteronism. Primary aldosterone is what we are called the conn syndrome. It is primary because of hypokalemia plus hypernatremia. If it will be secondary, that normokalemia we can encounter in the clinical practice. And then we are talking about first one, that is plasma renin activity high and plasma aldosterone concentration high, both are high. Then you should investigation for secondary causes of hyperaldosteronism, that is producing the aldosterone level, aldosterone in the body, that is renovascular hypertension, renin secreting tumor, malignant phase of hypertension. Here we are in our scenario we were talking about the fibromuscular dysplasia or renal artery disease, that is renovascular hypertension we are talking about. Okay, next in the next scenario we will be discussing about the further things inshallah. Then what will be the answer? First for renovascular hypertension, and the next was primary hyperaldosteronism, and third was Cushing syndrome. And in the next lecture we will be talking about primary hyperaldosteronism, as well as what is the lateralization index, what is selectivity index, how will we proceed to label it by sampling the inferior